Hi, my name is Pamela Coons, Associate Professor of Medicine in the Division of Oncology at Yale School of Medicine and Yale Cancer Center. I'm excited to announce ASCO's new open access journal, JCO Oncology Advances. As the inaugural editor-in-chief, I hope to support JCO Oncology Advances to become the premier platform to bridge the gap between accessible scientific research and clinical care. Stay tuned for more information, including new article types, at ascopubs.org/JCO Oncology Advances. We look forward to seeing your submissions in spring of 2024.
This JCO podcast provides observations and commentary on the JCO article, a population-based study to determine the health system costs of using the 21-gene assay by Mittman and colleagues. My name is Jennifer Griggs, and I am Professor of Medicine in the Division of Hematology Oncology and Health Management and Policy at the University of Michigan in Ann Arbor, Michigan. My oncology specialty is breast cancer. In this study, the authors use administrative data to report on actual cost data for 1,000 patients with estrogen receptor positive, node-negative breast cancer in Ontario, Canada. By comparing physician treatment recommendations before the results of the 21-gene assay were available to actual chemotherapy use, they were able to determine the impact of the assay on chemotherapy receipt. Particularly of interest are their analyses in cases of clinical uncertainty in which clinicians are most likely to order the assay in order to help decide whether or not to recommend chemotherapy. Despite a greater than 20% decrease in the use of chemotherapy in the base case analysis, the cost of care attributable to use of the assay in this cohort was increased by 3.1 million Canadian dollars, equivalent to 2.3 million US dollars, over a 20-month time period. In contrast, most economic analyses of the 21-gene assay have demonstrated that the assay results in net cost savings. The differences between the study by Mittman and the economic analyses by other authors are attributable to a number of factors. Among these are the differences in assumptions in previous economic modeling studies. In particular, compared with the present study, previous studies have assumed a greater decrease in the proportion of patients receiving chemotherapy with the introduction of the assay, higher costs associated with chemotherapy than the costs reported in the present study, and a higher proportion of chemotherapy-associated complications requiring resource utilization, such as emergency room visits. Each of these factors, separately and additively, would lead to a greater cost savings with use of the assay than that identified in the present study. An additional difference is the time frame for the Mittman study, which spanned 20 months compared with other studies, which generally included a longer time frame, incorporating more cancer recurrences and the associated costs of treating those recurrences. The authors will be following their 1,000-person cohort for longer-term follow-up. A major strength of the present study is the use of comprehensive administrative cost data from a universally insured, population-based study. Unlike a privately insured or underinsured patient sample, this approach is unlikely to have missed cost of care paid through patient assistance programs or patient out-of-pocket costs. While some might argue that universal coverage alters patient behavior and thus costs in terms of care seeking, the advantages of capturing costs of care in this way outweigh the disadvantages. It is important to note that the present study does not purport to be a cost-effectiveness study. The investigators do not, for example, quantify the cost per patient to avoid chemotherapy with the use of the assay. Similarly, the study is not a cost utility study, which would incorporate patient ratings of given health states and generate a cost per quality adjusted life year. Reasonable arguments could be made that the benefits of avoiding chemotherapy are not financial, but are personal. Yet, economic analyses have consistently supported the use of the assay on the grounds of cost savings through avoidance of chemotherapy costs. With all that being said, how can this study add to our understanding of the role of the 21-gene assay? First and most salient, existing cost-effectiveness models of the 21-gene assay can leverage these real-world cost data into their base case and sensitivity analyses to improve the precision of their cost-effectiveness analyses. Second, and most clinically relevant to current practice, we can and should be as judicious as possible in our use of the assay, both as individual clinicians and as a specialty. While every clinician intends to use the assay for its original intent, to identify patients who will not reap the benefit of chemotherapy, many of us have ordered it in patients with high-risk tumor characteristics, patients in whom we strongly suspect are likely to decline chemotherapy regardless of the assay results, or in patients who are poor candidates for chemotherapy. Finally, as genomic assays enter the field in other tumor types, we can scrutinize the costs of care before the widespread adoption of similar assays using analogous cost accounting to that applied by Mittman and colleagues. In summary, the methodology used in this paper and the findings illuminate the importance of accurate cost data and economic analyses of expensive technologies in cancer care. Incorporating this type of information into cost-effectiveness analyses and policy decisions and increasing clinician awareness about cost of care before widespread adoption will improve our ability to be responsible stewards of scarce resources while continuing to provide high-quality information support and preference-concordant care to our patients. This concludes this JCO podcast. Thank you for listening.
For more original research, editorials, and review articles, please visit us online at jco.org. This production is copyrighted to the American Society of Clinical Oncology. Thank you for listening.